Hello, and welcome to the ACR Journals On Air podcast. I'm your guest host, Parth Kumar, filling in for Vicky Shamagan. Clinical trials are essential parts of our healthcare system and link basic and clinical research with patient outcomes. However, the people that are enrolled in clinical trials are often not the ones that reflect the diversity of our patient population. Today, we'll be talking about a potential solution to this challenge with respect to lupus, specifically better provider outreach and education. The manuscript that details this promising approach is Training to Increase Minority Enrollment in Lupus Clinical Trials with Community Engagement, Enhancing Lupus Clinical Trial Recruitment Through Provider and Community Health Worker Engagement. It was published in Arthritis Care and Research and was the editor's pick for February 2025. A link to the manuscript and the disclosures are in our show notes for today. We are so grateful to be joined by the first and corresponding author of this study, Dr. Sarah Sheikh, who is also leading the project and has been working collaboratively with the ACR on this work for many, many, many years. Dr. Sarah Sheikh is the Linda Coley Sewell Distinguished Professor of Medicine at the University of North Carolina at Chapel Hill. Dr. Sheikh is a nationally renowned physician, researcher, clinical trials investigator, and educator. She is trained and triple board certified in internal medicine, rheumatology, and allergy immunology. She is the director of the clinical trials program at the UNC Thurston Arthritis Research Center and the director of UNC Rheumatology Lupus Clinic. She is principal investigator on numerous clinical trials and translational projects for new therapeutics and leads real-world practical models to increase access and opportunities for patients to participate in lupus clinical trials. She is also the lead investigator of a large federally funded project focused on utilizing machine learning models and artificial intelligence for early diagnosis of lupus. She also leads the UNC Lupus Multidisciplinary CAR-T and Cell Therapy Group. Dr. Sheikh has an outstanding reputation for her expertise among patients and colleagues across the institution and nationally, and patients travel around the country to see her in the clinic. She also currently serves on the ACR's board of directors. Dr. Sheikh serves as the chair of the Lupus Clinical Investigators Network, LUCIN, which is the largest and premier lupus clinical trials network in North America. So welcome, Dr. Sheikh. It is always a pleasure to talk with you.
Thank you so much, Dr. Kumar. Thank you for the very kind introduction, and to you and the ACR for inviting me to the podcast today.
It's quite an illustrious introduction. I want to get right to it, and I want to start off with the headline, right? So if a member of our lay community, a non-physician or a non-scientist is tuning in, so to speak, and they want to get a 2-sentence summary of the work that you did, what would you say to them?
So I'd say that this project is incredibly unique because it combines a formal educational intervention in the form of tailored online educational content with an interactive roundtable meeting format. And it facilitates discussions between clinical trial sites and healthcare providers and community health workers. So everybody through this project comes together to reflect on how we can develop pathways for patients to be referred to clinical trials. And in terms of what we're looking to measure, we are assessing changes in theory-based behavioral predictors of lupus clinical trial referrals and engagement, such as knowledge about clinical trials, attitudes, self-efficacy, and intentions.
Yeah, so that's fascinating. I want to ask, so as you've heard from the introduction, Dr. Sheikh is an exceptionally busy person, right? And that's only the tip of the iceberg in terms of the work that you do. Why did you pick this topic to study, and why is it so vital for us to improve patient representation in clinical trials?
That's an excellent question. And so if we take a step back, let's think about clinical trials and what we sort of want to achieve. So in clinical trials for any disease, not just lupus, we want to ensure that the data collected for investigational treatments reflects the populations that are most likely to benefit from those therapies. And so that's why thinking about this particular issue is important. We know that clinical trials of novel therapeutics in the United States have not been adequately representative of patients who often experience the greatest morbidity and mortality from the disease. So I want to emphasize that this isn't a challenge just unique to lupus, but it's a problem across the board, across disease states. But perhaps it's particularly relevant to lupus because, as we know, lupus or SLE, systemic lupus erythematosus, is a disease that disproportionately affects women, as well as patients of Black African ancestry and of Hispanic Latino ethnicity compared to other patient populations. So, we thought about the barriers that both healthcare providers and patients face when it comes to access and opportunity about clinical trials. So, in thinking about developing this project, we considered, what if we brought physicians and other healthcare providers together and included community health workers, so really bringing that community aspect into it and to discuss how we can best tackle this issue. And if you think about it, there's nowhere in our careers, if you reflect back, whether it's from medical school to residency to training to faculty, where someone really teaches us how to talk the talk, right? Like, how do we introduce clinical trials to our patients? What do we say? What are the words that we use? Why is it important, right? What are the things we need to know? What are the challenges that are faced by physicians and healthcare providers at academic centers? What are the challenges that community providers face in referring patients? So I think it's part of sort of addressing a global kind of larger problem.
And that's very ambitious, and that's very, very, very true. As we get into the paper just a little bit, I wanted to mention to the listeners that there's a bunch of acronyms and abbreviations that are used that you may or may not be familiar with. So I wanted to dive into them just a little bit. So I wanted to talk about the first one, which is timely. So can you tell us what timely stands for?
Absolutely. So the acronym TIMELY stands for Training to Increase Minority Enrollment in Lupus Clinical Trials with Community Engagement.
And from what I understand, that is the name of the full program that you have, correct?
That is correct.
Okay. And then the next acronym that I saw was mimicked, or I guess it's an acronym rather than an abbreviation. But yes, I guess it's mimicked. So what exactly is mimicked?
So MIMIT is, again, larger body of work that was done before this particular project. And that acronym stands for Materials to Increase Minority Involvement in Clinical Trials. And that is content that we developed as part of a different project, but leading up to this one. And we use that content in this Timely project. So it's a good way to think about Timely as, in some ways, an extension of the MIMIT project and with the addition of other components.
And I always love acronyms that are kind of like backronyms, that they have a meaning when they're put together. I think the next one I had a little bit of difficulty, but I think it's pronounced LUCIT. Can you tell me what LUCIT is?
Absolutely. So LUCIT stands for Community Health Worker Lupus Clinical Trials Training.
Okay. And then what exactly is, the CHW LUCIT?
It's really great that you ask. So, Lucid was a program, again, similar to Mimit, that was developed by the ACR and collaborators that focused on the use or partnerships with community health workers. So, one method of community engagement that many people may not be familiar with, it involves community health workers who are frontline public health workers who have especially close connections to the communities that they serve. And as you are probably aware, there is really a gap in terms of research that explores community engaged approaches to improve participation of patients in clinical trials. But what we do know is that previous interventions have shown success in training trusted members of the community about clinical trials and encouraging them to then connect with patients. So we adapted all of that into the Lucid program that was developed again prior to Timely, and then Timely serves as an extension of the combination of all of that work.
Lovely. And then I wanted to ask two more that one is I'm quite familiar with, but I don't know if many listeners are familiar with. But CME, tell us what CME is and why it's an important part of this project.
So CME stands for continued or continuing medical education. And for healthcare providers, as we all recognize, it sort of represents a continuous state of learning. And it's often a requirement for maintaining your licensure and ability to practice medicine. So it really represents this idea that we are continuously learning. And this is important because the content that we developed as part of this project and other projects through the ACR really has accreditation, so CME accreditation, which means that if you complete this training, you get credit. And what I do want to highlight for this particular program is that we developed CME not just for rheumatologists, but there was tailored content for primary care providers, there was tailored content for dermatologists and for nephrologists. So really anybody who touches a lupus patient was able to participate in this program and receive credit, CME credit. So I think this is probably one of the strengths of the program.
Tell us more about the Timely study. How did you go about it? Who participated in your study, and what did your team do exactly?
So before I get into that, I want to take a moment, if it's all right, to acknowledge the entire project team. So I get to have the honor of telling your listeners about the program, but as you know, it takes a devoted team to develop these programs. So first, I'd like to acknowledge the entire project team at the ACR and the ACR's Collaborative Initiatives or Department, or COIN. My co-lead for this project and work over the years with the ACR is Dr. Alan Anandaraja at the University of Rochester. Our project partners, which are community health worker organizations, both in North Carolina and Rochester, New York. KDHRC, which is a firm that also is a key project partner, my team at UNC Chapel Hill, and of course, all the humans who make this work possible. And of course, also to acknowledge our funders, because this project was part of the National Lupus Training Outreach and Clinical Trial Education Program, or the Lupus program that was supported by the U.S. Department of Health and Human Services, OMH. So, to tell you about Timely, as I mentioned, the unique aspects of this program are that it took the first piece, which is educational content, that is tailored to the unique role that healthcare providers play in engaging their own patients in discussions about opportunities to participate in lupus clinical trials. So the goal here is that the healthcare providers had the opportunity to access, learn, and engage with this online content, right? On their own terms, on their own time. And through this, they had the information that they needed to potentially help patients make informed decisions about clinical trial participation. So this program is completely clinical trial agnostic. So it's not really focused on one particular clinical trial or another. It's really this sort of general idea about clinical trials. And as you know, probably, and recognize, we really have work to do when it comes to creating a culture of integrating clinical trial opportunities into our discussions with patients, right? So really, I think I would love to get to a point when we can say to a patient sitting in front of us, here's option 1 for treatment, right? Here's option 2. What about the opportunity to participate in a clinical trial, right? So allow patients to make informed decisions, empower patients to just know, right, that this is an option. So the Timely program, that was that first component, which is the educational component. And then once both healthcare providers and community health workers had completed the online educational component, they were able to come together to participate in these roundtable discussions.
So I love that term, roundtable, and it kind of reminds me of King Arthur and ancient medieval legends about, Arthurian mythos and stuff. Can you help me imagine what exactly a roundtable looks like in the 21st century in America rather than like the mists of English history mythology?
I love that you said that. So really, what we take from King Arthur's round tables is the symbolism, right? So the round table, the shape of the table, the round shape of the table signified equality and unity, right? There's no designated head or foot of the table. So it implied that all those who were seated at the table are of equal status. There's no one who could claim precedence over the other, right? That was that design, essentially. And so we held dedicated roundtables, both for physicians and healthcare providers, as well as for community health workers. And so to answer your question, we really sat around a table, but we sat around either a virtual table, so in virtual space, or in person, because this project was conducted at the University of North Carolina as well as at the University of Rochester. And then what could be more 21st century America, right, than a food delivery service? So we incentivized participants by giving them food delivery service gift cards. So food showed up at their doors, and then they were able to engage in the roundtable. And we structured these roundtables as informal conversations in which the small group of participants engaged in a collaborative exchange of ideas and perspectives. And really, what we were aiming for was equal participation and open dialogue. And so we truly valued everyone's perspective who came to the roundtable discussion, whether someone had experience with clinical trials or not, whether they were based in the academic environment or in the community, whether they were a fellow or whether they were an attending. We strived for open and equal participation. And what I'll tell you is that it was great because it was a brainstorming session and we were able to generate ideas, right? We were able to have extensive knowledge sharing. People could learn from each other's experience and expertise. We were able to, and I would say this is the highlight of the project, we were able to build relationships, right? We fostered a sense of community and collaboration. And then we were able to talk about solving this problem, right? How can we come together to address this problem of underrepresentation in clinical trials and in general, just participation in lupus clinical trials and develop practical solutions?
Hmm. That sounds positively utopian to me. It sounds like, this model or this approach, it could be generalizable, right, to other clinical trials and other diseases. Can you comment on that a little bit?
Absolutely. And I think that's really one of the key strengths of this program. Like I said, even when it comes to lupus clinical trials, it was really clinical trial agnostic. So I think this idea, this approach of an educational component and then a really sort of live, interactive roundtable discussion where you enter that discussion with openness to solve a problem, right? We really want to come away from sort of, at least this is my personal opinion, right? From stating and restating the problem to like, how can we develop solution focused frameworks, right? To tackle the problems. So you could take this idea, like I said, it's not unique to lupus. We really need to encourage clinical trial participation because that is the way we advance science and bring novel therapeutics to our patients who need them the most.
Yeah, and I think it's not just your personal opinion, it's my opinion too that, my goodness, we do need some frameworks in order to elaborate these kind of solutions for many things. And that's why I read it with such eagerness. So what were some things that you learned from this project, and were there any surprises that you found?
Yeah, I think in terms of a surprise, it was really this idea that the majority of healthcare providers and community health workers had never really received any sort of formal training or guidance about how to do this, right? So if I were to say that was sort of a key messaging that came up. The other thing I think, which is not really a surprise, is that we were able to highlight barriers both from the healthcare provider and the patient perspective, right? Where are the gaps? We, as you know, don't have as physicians or other people working in healthcare, we don't have enough time, dedicated time or resources to have effective conversations, right? It's not just training, it's just a lot of gaps in how do we do this. There are implicit biases, there's just logistical concerns. And then there's the thing that we don't think about is we just assume that everybody knows what we know, right? But really, does everybody have knowledge about what clinical trials are ongoing, right? How do I talk to my patients about them? How do I refer my patients to the clinical trials? And so I think that was front and center that emerged from this conversation. And then I think one of the other things that was important and impressive was how do we learn to have conversations with our patients, discussions with our patients about clinical trials in a way that is effective and comfortable and with cultural humility? How can we all sort of think about ourselves as one community in terms of really with the patient at the center of it all, right? With patient centricity, think about how can we improve access and opportunity for our patients. So I think that that's probably the focal point of this project. And I think we demonstrated through this project that across the board, there was increase in knowledge, right, when it comes to understanding about lupus clinical trials. And then we were also able to impact behavioral predictors when it comes to clinical trial referrals.
So, one of the words that you used in your answer that really intrigued me was about everybody, right? And I'm wondering about the different groups and subgroups that you had in this timely project. Can you tell me a little bit about how the different groups and subgroups, how that kind of interaction led to the different outcomes within the timely project?
As I mentioned, in our final sample, we had 40 healthcare providers as well as 18 community health workers. And the healthcare providers spanned not just rheumatology, but multidisciplinary. That was, again, strength of this project, the multidisciplinary aspect of it. We had primary care providers, we had dermatologists, we had nephrologists. And then also within the healthcare providers, we also had nurse practitioners and physician assistants. And then also, as I mentioned, we had attendings and we had fellows. And then again, as I emphasized, the participants were recruited from two geographic areas served by the University of North Carolina at Chapel Hill in terms of the healthcare providers, and Cure America's Global, which is the community health worker organization in North Carolina. And then at the University of Rochester Medical Center for the healthcare providers, and then the Community Health Worker Association of Rochester in New York. And so we really had a fairly, I think, broad representation of participants who engaged in the program. And as I mentioned earlier, we were able to show that after participating in the timely project or intervention, whatever you'd like to call it, the knowledge scores increased significantly and showed statistical significance for both healthcare providers as well as community health workers on completion of the knowledge component. And then after participation in the roundtable discussions, the composite scores for self-efficacy and intentions significantly increased for healthcare providers. And we were able to show that these provider self-efficacy gains were sustained at the 3-month follow-up.
So I love that you mentioned about self efficacy and intention as outcomes, since knowledge is important, but by itself, it seems a little incomplete. Can you comment on why it's important to study these behavior predictors in addition to assessing that increase in knowledge?
Absolutely. I think the first reason, obviously, to study behavior is because oftentimes the end result, which we are trying to measure, which is the actual referral of patients to clinical trials, and then actual enrollment, sort of screening, enrollment, engagement takes a while, right? And I will tell you that that is the next stage of this project that is currently ongoing. So we've been able to take that further. But to take a step back, when you look at behavioral theory, so the theory of planned behavior suggests that an individual's intentions to perform a specific behavior are actually the strongest predictor of their actual behavior. So if there was some way that we were to gauge, whether or not someone was going to do something, the intention to perform it is probably, based on behavioral theory, one of the stronger predictors. Now, self-efficacy, to me, as you also highlighted, is an important component because it refers or really gets at an individual's ability or belief in their own capacity to execute a specific behavior in order to achieve a desired outcome, right? So, for example, it's one thing to say, yeah, I'm going to go ahead and refer my patient to a lupus clinical trial. But it's another thing to feel confident that you know how to do that. Do you know what I mean? That you feel comfortable and confident that you know the various steps needed to go ahead and do that. Like, do you know what clinical trials are currently enrolling in your area? Do you know who to contact, right? If your patient should probably or potentially qualify. And I'll say to you that the one thing we emphasize throughout this project, and I continue to emphasize to all our colleagues, is that we're not asking anybody, like a treating clinician, to make a decision in their busy clinic about whether or not a patient qualifies for a clinical trial. All we're asking and all the learning through this project is really saying, think about the option of a clinical trial just as you would any other therapeutic option. Introduce that idea to a patient, like, hey, do you want to learn about clinical trial opportunities that could be available? And then once we build these strong pathways of connection and collaboration, there should be a easy path by which you say to your patient, hey, someone from the clinical trials team here will contact you if you're willing and open to learn about it. So to go back to your question, the knowledge component is the first piece of, I need to learn the importance of this. Why do I need to do this, etc.? How do I do this? But then the behavioral components is, do I now feel empowered to complete this task? Do I have all of the tools that I need?
As you may guess, I'm a huge fan of this study, but at the same time, I don't want to oversell it. Since you're the first and corresponding author, can you tell me and our listeners, what do you think are some limitations that we should all be aware of?
Absolutely. Obviously, the first limitation is that the project was limited to two specific geographic areas where the project was implemented, right? And we have an entire country. So this only represents, obviously, the perspectives of the individuals in those areas. So, one, obviously, it could be difficult to generalize to all regions. So, the future iterations of this and other programs, in our opinion, should really focus on expanding the outreach to include a broader sample of geographic locations. Second, obviously, numbers, right? We felt like we did great training this particular number of healthcare providers and community health workers, but we have so many physicians and healthcare workers and healthcare providers and community health workers to train, right? And to help include in sort of this mission. And I think also importantly, and this is something that's close to my heart, is that it's great that this project was very sort of tech friendly, right? There was an online enrollment, there was survey components of the study. And it's hard now, obviously, in our world to imagine that there are individuals who have limited digital literacy or access, right? But especially for our community health workers, there are individuals that probably maybe did not feel comfortable with that and probably therefore did not want to engage or participate in this project. And then obviously, whenever you have self-reported outcome measures, similar to what we use, it's subject to what's called a social desirability bias, right? We say the things we think we want people to hear, right? And so it didn't, in this particular iteration of what we published, did not include objective measures of patient engagements and referrals, which is now the next stage of the project that we're currently doing. And so when we published this, we already sort of stated upfront that we need to examine objectively the measures of lupus clinical trial engagement and referrals. So really tangibly show how did this intervention translate into actually the numbers of humans that are being referred to lupus clinical trials. And I think one other limitation that maybe you might call out is that we showed an increase in healthcare provider intentions to refer patients to lupus clinical trials at 1 month after this program, but that wasn't maintained at the 3-month follow-up survey. So you could ask, well, why is that? And I would say, well, it approached significance. And one way to correct this, obviously, always is a larger sample size of participants. But then it also could be, out of sight is out of mind. And the lack of continuous contact between the research teams, the clinical trial sites, and the participating providers between month 1 and month 3 could have also resulted in the fall off of intentions to refer. So that brings us back to some of the work that we're doing now, which is constantly making sure we are engaging with everybody to make sure that this message is front and center in everyone's minds.
This brings me to my next question, but you gave some spoilers to it, so this may not amount to much, but let me read out the last sentence of your manuscript. It's really full of promise for the future. It says, Findings from this study will be used to inform future iterations of Timely and other intervention programs focused on advancing representation of racially and ethnically diverse patients in lupus clinical trials. Let me know, should I feel so optimistic? I mean, what sorts of amazing things are headed down the pipeline, and how do you define success in this endeavor?
Thank you. So, yeah, I think, I'm a eternal optimist, so I share your enthusiasm as well as your optimism. But I think there's a lot of work that needs to be done. And yes, exciting stuff happening now. As I mentioned, we're really looking now at the tangible aspects of this program and developing other programs similarly that really sort of shift in some ways the focus from the patient is at the center of it all, right? So patient centricity is key, but to take that some of that responsibility and shift it to the healthcare provider. So yes, we teach and tell our patients to advocate for themselves, right? Talk to your doctor about if a clinical trial is an option for you. But at the same time, we're also messaging around helping healthcare providers, physicians really also introduce these conversations with their patients. And what we really need, and I think we're working on and messaging, is that physicians and healthcare providers need dedicated time, resources, and we need innovative solutions to bring clinical trial opportunities to our patients. So, really, we need clinical trial infrastructure reform at every level to be able to achieve this goal. And in terms of success, I maintain that success is a dynamic state. And I think it's influenced by how well we, as physicians and healthcare providers, deliver information that matches our patients' abilities, their needs, and their preferences.
So listeners may have picked this up, but Sarah and I, we share this eternal optimism. But there's more than just that we share. We share actually a very similar career path. In fact, this may be the first ever podcast in history in which both the host and the guest are dual certified allergist, immunologists, and rheumatologists. So tell me, why are we so crazy to do all of this? And then what drives people like you and me?
That's actually a really unique and fun fact for sure. Thank you for bringing that up. So some might say, right, like our pain is self-chosen, lots and lots of trainings, board exams, recertifications, but so incredibly rewarding. For me, and I'd love to hear your perspective too, but for me, it's really the desire to connect the dots, really as a true clinical immunologist. At least in my head, and then also in my practice, it comes together full circle, right? To understand the full spectrum of immune mediated disease from immune deficiency on one side, where patients really have an immune system that isn't functioning, to dysregulated immune responses in the form of allergic disease, and then full circle autoimmunity on the other side of that. And then the intersection of all of these conditions, oftentimes in the same human, is so fascinating and obviously very relevant to the disease that I study, which is systemic lupus.
And you're absolutely right in terms of we choose our own pain. But this pain is like a really enjoyable pain. And I kind of agree with you about connecting the dots with immunology in general. If you understand the details, you understand the big picture. And if you understand the big picture, you understand all the details. And just connecting those together, right, to extend the metaphor, really brings up this beautiful picture that's still evolving, that we're still learning through things like clinical trials. And that's what I absolutely love. That's all the time we have for today. I'm deeply grateful for your time, Dr. Sheikh. Dr. Sheikh and so many others are doing outstanding work in helping to improve access and opportunity for our patients to participate in cutting edge clinical trials and the integration of basic and clinical research into clinical practice. It's not an easy task by any stretch of the imagination, but talented and dedicated people like Sarah do not choose to undertake easy tasks to begin with. So thank you all for listening to this podcast. We will see you next time. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRoom on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts. Thank you.
Thank you so much for having me.